Good evening, doctors. My name is Rahul Desai, and on behalf of FDC and MedTalks, in our journey of 52 weeks of diabetes essentials, I hereby welcome you all to today's live module brought to you by Enerzal Zero and in memory of Dr. K.K. Aggarwal, sir. Dear viewers, today Dr. Sanjay Kalra, sir, will take us through today's topic, that is of diabetes formula, which is very much essential for doctors in their clinical practice for proper control of glucose and these further protocols. Dear viewers, today's session is a recorded session of Dr. Sanjay Kalra sir, as sir is out for his one of the urgent commitments. But sir will be back with us for question and answer sessions live. So before I hand over the platform to the technical team to play the recorded session of Dr. Sanjay Kalra sir, let me have the opportunity of announcing the winners of last episode. The winners are from Delhi, we have Dr. Umesh Kumar Malhotra, Dr. Vinod Ladia, Dr. Rajan Pradhan, Dr. S.R. Elwadi. From Haryana, Dr. Manish Kumar Jain, Dr. I.C. Garg. From Punjab, we have Dr. Namrata Puri and Dr. Sanjeev Puri. Then from Dr. Jitendra Shah from Gujarat, Dr. S.S. Rana, Dr. Gautam Datta from Jharkhand, Dr. K.M. Prasanna Kumar, Dr. Ravindra Nath Katta from Karnataka, Dr. Deepak Paradkar from Madhya Pradesh, Dr. Gangadhar Rath from Odisha, Dr. M.R. Chipa from Rajasthan, from Maharashtra, Dr. Jayshree Salyan, Dr. Damodar Jeswani, Dr. Kulbhushan Tandon, Dr. Dharmika Tandon, Dr. Abhijat Sangvi, Dr. D.G. Parmar, Dr. Jagrut Dhabuwala, Dr. Farid Kimani, Dr. Hutokshi Zaruliwala, Dr. Bharat Jain, Dr. Somnath Suryavanshi, Dr. Kirit Lallan, Dr. Bharat Jain, Dr. Nirmala Lulla, Dr. Sashikant Shende, Dr. Nayana Sheth, Dr. Sanjeev Desai, Dr. Harsh Shah, Dr. Neeta Kochar, Dr. Irfanullah, Dr. Surjit Kalsi, Dr. Arun Kumar Garg, Dr. Ashwini Kumar, Dr. Rajesh Jain, Dr. Javed Ahmed, and Dr. Suresh Kushwa from Uttar Pradesh. And from West Bengal, we have Dr. Shantanu Kumar Bhattacharya, Dr. Dibyendu Bhattacharya, and Dr. Dheeraj Kumar Haldar. So, congratulations to all the winners. And with this, I hand over the platform to the technical team so that they can play the recorded session of Dr. Sanjay Kalra, sir.
Good day, friends.
Rituma, can play the video, ma'am. Sorry for the technical disturbance. There seems to some issue with the session video.
Friends, and a warm welcome to this edition of Diabetes Essentials. India is a very special country. We are very good at innovation. We are very good at invention. But what we are best at is improvisation. And that is what we discussed last week when we spoke about diabetes jugaad. Apart from the jugads that we discussed, there are many other ways in which we can improve, in which we can innovate, in which we can help ourselves do a better job of diabetes care. One of the ways in which we do this is by employing something that is called heuristics. Now, heuristics is a very heavy sounding kind of an English name, but in simple words, what it means is shortcuts. That's all it means. A heuristic is a shortcut, or it is a rule of thumb that we follow, or it is something that helps us facilitate our decisions. The term that is used by psychologists is fast and frugal rules. So in a busy clinic, like we all face every day, we have to be fast. In a resource challenge setting where you cannot get too many investigations done for your patients, you have to be frugal. So being fast and frugal, we need to employ some heuristics, something to fall back upon. Let me discuss 4 types of heuristics before we go on into today's discussion. All begin with the letter A. First is archetypal. An archetypal heuristic would mean maybe somebody has come from Eastern India, so the patient has kala azar. Somebody has come in current days from Uttar Pradesh, so the patient has dengue fever. This is an archetype. Somebody has got fever in Kerala, it has to be COVID. You create an archetype, or you create a platform upon which you make your decisions. In diabetes, archetypal heuristics do work. Somebody is obese, it means he has type 2 diabetes. Somebody is lean and thin, the patient may have type 1 or pancreatic diabetes. If the patient is fair complexioned, in my clinic, chances of being type 1 diabetes are more. If the patient has a normal Indian complexion, chances of pancreatic diabetes are more. So this is an archetype which I follow. There are also availability heuristics. Availability means your brain uses whatever is available to it. So maybe in the last 1 month, I read a few news articles, or I happened to listen to an article which talks about type 3 diabetes, Alzheimer's disease, and diabetes. Then I will begin looking for Alzheimer's disease in all my patients. On the other hand, if I'd happened to attend a couple of lectures on maybe Jugaad, diabetes Jugaad, then I will just keep on searching for opportunities when I can play that Jugaad. Affect heuristics are very important, and they do affect me as well. Let me be the first one to admit this. Affect means what is my affect or what is my mood at any point of the day. There is something known as compassion fatigue. If it's early morning, I'm in a happy mood, I will spend more time motivating a patient to take insulin. If it's afternoon, I am tired, then I may not spend so much time motivating a patient to take insulin. I will write a prescription for oral drugs and ask the patient to come back next week. So my affect or my mood is affecting my decision making. This is compassion fatigue. It is also physical fatigue. So be aware that in your clinics, try to avoid physical fatigue, try to avoid compassion fatigue or emotional fatigue. Take breaks every now in between so that you can do a good job for all your patients. The fourth heuristic is known as anchoring heuristic. And we'll talk about this later when we come to our discussion on insulin today. So, four types of heuristics. These are important for diabetes practice. They are important for everything we do in our clinic, in our life. So, archetypal, availability, affect, and anchoring. We should be aware of these, and we should be able to use these to our benefit. We should be able to use these as strengths, not as weaknesses. Now, our work today is to talk about formulae. So, when you talk of formula, you think of numbers. So, let's just think of some numbers and how we can use them. It's difficult to remember so many facts in medicine, but if you put them together, it becomes much easier. So, HbA1c target is less than 7. The WHO definition of severe anemia is less than 7. 7% A1C, 7 gram percent hemoglobin. That is the definition of severe anemia. Thinking of hemoglobin, as the hemoglobin falls by 1 gram percent, the ESR rises by 10 millimeter. This may not be very accurate, but it is a heuristic. It is something that makes you think fast and frugally. What is our blink rate? Our eyes are blinking. How frequent is it? We do not know. But if we anchor it with the respiratory rate, it becomes easier. But now, what's my respiratory rate? This is 1/4 of my pulse rate. So now this is anchoring. I can remember 3 facts at the cost of just 1. So my blink rate is equal to my respiratory rate, which is 25% of my pulse rate. We said that when we think of formulae, we think of numbers, but we can also think of letters as well. So when will you screen for diabetes in your clinic? When will you counsel your patients to get their family members, friends, and colleagues screened? The answer is the dholki or the drum. In Hindi, we say, diabetes ke dhol baj rahe hain India mein. The drums of diabetes are beating. So when will we search for diabetes and pre-diabetes proactively? Dholki tells us that we will search for diabetes if there is darkening of skin, that is acanthosis nigricans, D. H for hypertension, history of GDM in the past, history of diabetes in the family, history of cardiovascular disease in the family or in oneself. O for obesity, obstructive sleep apnea, and ovarian syndrome, polycystic ovary syndrome. L for fatty liver and lipidemia, dyslipidemia. K for kidney disease, which is assessed by albuminuria or microalbuminuria. So if you see a patient with albuminuria, you must get a glucose done. And I is for infections. There are some infections which are directly and significantly associated with the risk of diabetes. These include hepatitis B, HIV, tuberculosis, and STDs, sexually transmitted disease or genitourinary diseases. This year, COVID-19 has been added to the list. But apart from these, if your patient comes with any sort of infection which is resistant or refractory or recurrent, you must screen for diabetes. If your patient comes with an infection that is significant and has a fair chance of impacting life or organ or function, then again, a glucose is mandatory. We have spoken about some numbers. We have spoken about how to assess, how to screen for diabetes. But after that, the story is not over. Once you have diagnosed diabetes, you have to screen for complications. Now, the three macrovascular complications go together. They go hand in hand. This is a heuristic. Coronary artery disease, cerebral artery disease, and peripheral artery disease. And the chances of polyvascular bed involvement are quite high in diabetes. So if you have a patient with CAD, do think of stroke. If you have a patient with PAD, peripheral arterial disease, do not forget coronary and cerebrovascular beds. There are three microvascular complications as well: retino, neuro, and nephropathy. The heuristic here is that if there is one macrovascular disease, search for the other. If there is one microvascular disease, search for others. This is known as reno-retinal association. Reno-retinal association. There are some situations where there is reno-retinal dissociation as well. The retinal health is different, the renal health is different. In such cases, actually, you will think of non-diabetic causes. But the heuristic here is that there are three bridges between macro and microvasculature. So if you have a patient with microalbuminuria, assess for both macro and microvascular health. If you have a patient with erectile dysfunction, assess for both. And if you suspect cardiac autonomic neuropathy, assess for both. So cardiac autonomic neuropathy is actually the bridge between macro and microvascular health. We have spoken of macrovascular health and we spoke of coronary artery disease. But you will find that in many people with diabetes, patients have silent or atypical angina. So they will not come with classic pain. So these ABCDE symptoms, and I would like to thank Dr. Kamal Kishore, a cardiologist from Karnal in Haryana, for helping me with this. These ABCDE heuristics help us remember when to focus more on angina. You may wish to treat the patient yourself. You may wish to refer to a specialist, but you have to think of the heart. And these are patients who come to you in an acute setting with atypical site pain, anywhere from the jaw of the mandible to the umbilicus, breathlessness, clamminess of the skin or profuse sweating, dry mouth, ABCD, all occurring at exertion or exercise and then relieved by rest. If it is a myocardial infarction, it will not be relieved by rest. In other settings, you might find another set of ABCDE, A for arrhythmias, B for biochemical abnormalities like albuminuria, dyslipidemia, we mentioned them just now, C for claudication pain, that is peripheral arterial disease, D for dizziness, which might imply cardiac autonomic neuropathy, and E for erectile dysfunction. So, arrhythmia, biochemical abnormality, claudication, dizziness, and ED. All these may suggest a myocardial or polyvascular bed involvement. So these heuristics also help us and keep them at the top of your mind. They help us take a good history and help us triage our patients. In recent years, we have begun understanding that coronary artery disease is different and myocardial disease is different. So Heart failure is something that is often associated with CAD, but not necessarily always. So, when you look at the classification of heart failure or the grading, it is graded as stage A, B, C, D. A, B are pre-clinical, subclinical, and CD are clinical. A good doctor should be one who is able to detect heart failure in the preclinical stage. Another A to F heuristic for this. Here we go one step ahead, one letter ahead, up to F. Patients with severe anemia, AV fistula, or alcohol abuse may be prone to heart failure. Those who take bad drugs, B is for bad drugs like those which maybe impact the conduction of the heart or which reduce the contractility of the heart, conduction or contractility. Examples would be anti-cancer drugs, even some antibiotics like azithromycin, antifungal drugs. These can precipitate heart failure in patients who are already prone to them. C is easy. C is for coronary artery disease. D is also easy. D is DHOL, what we just discussed. Diabetes, hypertension, obesity, dyslipidemia, fatty liver. Many endocrine disorders can precipitate heart failure, predispose to heart failure. These include hyperpituitary, hypopituitary, hyperthyroid, hypothyroid, hyperadrenal, hypoadrenal, hypergonad like PCOS, and hypogonad disorders. So be aware of these and at least think thyroid whenever you have a patient with heart failure, and think heart failure if you have a patient with uncontrolled thyroid disease. F is for fever, either a history of rheumatic fever in the past. I think I am the last generation of India that suffered from rheumatic fever. It is quite rare now. And also a family history of cardiomyopathy. Now, we've spoken of screening for diabetes, we have spoken of managing complications. We have focused a lot of our heuristics on heart health. And this is important because at the end of the day, it is the heart which is going to impact the morbidity and mortality of your patients. So we need to take good care of the heart. But we do that in various ways. And one of the ways in which we take care of the heart is by giving good glucose control to our patients. So now let us imagine that we are playing on a football pitch. If you want to be aggressive, you want to control glucose very fast. On top of a metformin therapy, the drug of choice here for us will be modern sulfonylurea, glimepiride and glycoside modified release. If you want to play midfield, an in-between kind of a game, then gliptins, acarbose and voglibose are good choices over and on top of metformin. And if you want to play a defender role, you just want to defend your patient without being too aggressive, then GLP-1RA and SGLT2 inhibitors are the best defenders of heart health. The same analogy we'll use for insulin a couple of slides later. But while we are on oral drugs, let's look at this slide. We discussed it last time as well. Depending upon the risk of hypoglycemia and weight gain, you can classify your drugs. Depending upon the strength of cardiovascular risk reduction, drugs can be classified. And also you can choose drugs based upon the body weight of the patient. We call it a varocentric approach, VARO, Varo, or BARO, Baro, barocentric approach to diabetes care. If you have patients who are obese, then GLP-1RA, SGLT2 inhibitors are good drugs. If you have patients who are lean, then sulfonylureas and DPP-4 inhibitors may be better. If our main aim is to prevent hypoglycemia, then again GLP-1RA, SGLT2 inhibitors, alpha glucosidase inhibitors will score. If our main aim is to reduce CV risk, then SGLT2 inhibitors and GLP-1RA are the best. But this slide helps you because it tells you that if you have a patient who needs swift glucose control, then the answer is sulfonylurea. If you have a patient whom you're going to treat for a long time and you feel the patient is not going to come back to you and patient may have to manage on his or her own, then gliptins are a good choice along with metformin. And if your main aim is to defend the heart, then it is GLP-1RA and SGLT2 inhibitors. This slide also we have discussed more than once in the past, a phenotypic approach to glucose lowering therapy. You look at the phenotype and then decide what drug to use. We are speaking of oral glucose lowering drugs now. And there is a definition of OAD failure. This is by Dr. Sushil Jindal from Bhopal. He says that at least three drugs have to be given in optimal dose, including metformin and preferably including sulfonylurea. And if you cannot get control with these, then you can label the patient as having OAD failure. Do note that he stops at three drugs. He does not take it up to four or five. And he does say that you have to ensure that diet and exercise have been optimized along with stress management before you diagnose OAD failure. Patient may be taking three drugs but may not be following diet and exercise. Then you cannot label that patient as having OAD failure. If, however, the patient does have OAD failure, or patient is sick, or severely hyperglycemic, or symptomatic, then we need insulin. Let's talk about the anchoring heuristic here. When you are speaking with your patient about insulin, the anchoring heuristic says is that you give the patient an anchor. So my communication style may be, according to the textbook, you need 4 injections of insulin a day. If the patient says, yes, I don't mind, then you say, but see, you are such a good patient. Let me try with 2 injections pre-mixed. If it doesn't work, we can always increase. Also, if the patient just steps back and says, doctor, I would die rather than take insulin, 4 injections a day, that's too much. Doesn't matter, madam. Let's begin with 2 or 3. So you begin negotiating. Negotiate about the number of injections, about the number of delivery devices as well. If you can use the same delivery device and the same injection multiple times a day, it becomes much easier for the patient. So again, that football analogy, if you want to play forward, you have a patient who is severely hyperglycemic, sick, symptomatic, needs immediate control to resolve an infection or inflammation or to go for surgery, then basal bolus regimen. But for most of us in practice, midfield playing is what we do, and premixed insulin is the safest, most appropriate. If we want to be really safe and just go on the defending style, then basal insulin is a good drug to use. So 3 types of regimens. Midfield is mixed, defender is basal, and forward is basal bolus. How do we choose between these? Let me try to bring objectivity to our choice. Now let's take some key numbers. This is another diabetes formula. Now the definition of diabetes is post-load 200, fasting 126. So 200 minus 126, 74. The definition of pre-diabetes is post-load 140, preload 100. So 140 by 100 minus 100 is 40. Another definition of diabetes includes HbA1c, 6.4. Let's just take it to be 6.3. So 126, that is the fasting, divided by 6.3, it's 20. Now, armed with these numbers, 74, 40, and 20, we can decide what kind of therapy to give our patients. If the postprandial excursion is more than 40, and especially more than 74, maybe PP of 250 and fasting of 150, the excursion is 100. That means I have to give a prandial insulin component. Have to means have to. So either I can give basal bolus or I can start with premixed. On the other hand, if the PP excursion is less than 40, maybe PP of 220 and fasting of 185, the excursion is just 35. Now here I need to focus on that 185, so a basal insulin may suffice. Another formula, fasting glucose divided by A1C, and see 126 divided by 6.3 was our anchor. If it is more than 20, fasting divided by A1C is more than 20, it means there is predominant basal hyperglycemia. Fasting of maybe 250 and HbA1c of 10. 250 divided by 10 is 25. So I need to focus on the basal insulin. I need to give basal insulin to focus on the fasting hyperglycemia. If, however, fasting is 150 and A1C is 10, 150 divided by 10 means 15. This is a low number. It means there is more of prandial hyperglycemia. So I will need more of prandial coverage as well. So this is a simple way of bringing objectivity to choice. We have talked today about heuristics. We talked about anchoring. We showed you how to anchor your patient. Madam, ideally, I should be giving you 4 injections or 10 tablets a day. but how much do you want? Let's share the decision making. Let's share the responsibility. That was an anchoring heuristic. An affect heuristic: be insightful about your own mood, the mood of your staff. If you are happy, if you are compassionate, you will be able to help your patient more. If you feel that you are getting tired physically or psychologically, it's time to take a break. Take a 5 minutes break for a cup of tea. If you feel you cannot do that, you just share responsibility. You send the patient to your receptionist, or you buy time. Why don't you get a urine sugar done? Why don't you get a blood glucose done again after half an hour? Why don't you take a bottle of Enerzal Zero? Madam, you have come complaining of uneasiness or ghabrahat or sustu or susti. There can be many reasons for this. It just might be some electrolyte deficiency. So why don't you take this bottle of Enerzal Zero? Maybe along with that, a tablet of clonazepam or Stemitil, promethazine, whatever you feel is appropriate. And let's check your BP and glucose again after 15 minutes or 30 minutes. This gives you a breather. Patient also feels happy that he or she was taken care of. Another was availability heuristic. So availability, we said, is what you listen to. Now that we have listened to all these, the availability heuristic tells us that we will focus more on cardiovascular health and more on phenotypic triage in our patients, based upon what we have discussed today. That is a welcome development, I feel. And another heuristic that we discussed was archetypal. Over the past few weeks, we have been discussing archetypal heuristics. We have been creating archetypes. Archetype of a patient who needs sulfonylurea, archetype of a patient who needs insulin. So that is the way to go. Archetypal heuristics will help. Do remember that apart from type 2 diabetes, your patient may have adult type 1, that is LADA, or pancreatic, or MODI. So be aware of all these also when you use these heuristics in practice. We've had a great day today. Last week we spoke about Jugaad. This week we've spoken about formulae or heuristics. And now let's see what the answers were to the questions that we got from last week. This measure does not help to prevent diabetes complications, eliminating all carbohydrates from diet. We do not need to give a zero carb diet. That will actually cause more complications in diabetes. And which electrolyte deficiency uh, uh, causes all these? The answer is actually hypocalcemia, but the answer was given in the question itself. Hypomagnesemia is also associated with all these. We'll move on to our questions for this week, and then we'll take questions and answers. In the meantime, I wish you all the best with your clinical practice. Do enjoy using these jugaads or improvisations and these heuristics or shortcuts for the betterment of your patients.
So, viewers, we have Dr. Kalra sir live with us to take on the questions of this module. Good evening, sir. Good evening, sir.
Good evening, everybody, and I hope everybody has had a pleasant Sunday.
Yes, sir. So, the platform is over to you now, sir.
Thank you. We need the slides for this week's quiz questions. I hope Ritu has them. In the meantime, let me take some of the questions that have come in. We have many questions requesting for explanation in Hindi. I apologize. This is a national webinar and we will be speaking in English. This particular webinar is focused on doctors. And for all those of you who wish to learn about diabetes in Hindi, जो भी हिंदी में सीखना चाहते हैं शुगर या शुगर की कॉम्प्लिकेशंस के बारे में, जैसे शुक्ला साहब हैं, शिवम जी हैं या नितिन नरूला जी हैं, एवरी मंडे एंड थर्सडे, हर सोमवार और वीरवार 7 से 8 बजे 7 to 8 p.m. डॉक्टर के मेड टॉक्स में मैं आपके लिए हाजिर होता हूँ. वी डिस्कस डिफरेंट एस्पेक्ट्स ऑफ पब्लिक हेल्थ, हेल्थ फॉर द जनरल पब्लिक, हर सोमवार और वीरवार. Let me take up some of the questions that are related to today's topics. There is one question from Dr. V. Upadhyay. Will sulfonylurea cause earlier loss of beta cells in the pancreas? Partially, yes. How good is vildagliptin to control diabetes in a patient with tuberculosis? In tuberculosis, if your patient is eating well, taking adequately, then metformin would be the first line, like routinely. However, if patient is cachexic, patient is asthenic, not able to eat well, struggling with the side effects of drugs like gastritis, then insulin would be the best choice. Out of all the gliptins, vildagliptin is the least preferred when it comes to hepatic health. So, because there are multiple drugs that are being given in tuberculosis, and all these drugs themselves may have some hepatic toxicity, it would be a good idea to avoid vildagliptin and use other drugs. Dr. Junaid has a question. Type 2 diabetes with high glucose, maybe random 300 HbA1c 12.5. This patient was started on premixed insulin and now requires 30 units. What would be an ideal time to switch to OADs? So, in such patients, I myself try to switch to OADs after some time. We give them about 6 weeks, and what I tell them is let the HbA1c come to around 8, 7.5, 8.5. Then we'll come to tablets. We don't do it suddenly. We tell them just like you follow the rules while driving. You don't go from fourth gear to zero gear to neutral immediately. So maybe I will stop one dose of premixed, change it to sulfonylurea plus metformin, see how glucose behaves after about 10-15 days, and then stop the second dose. Some people we may not be able to stop the insulin totally, but we may be able to bring them down to maybe a basal insulin of 10 units per day. So each patient is different, but do go stepwise. And the question was the ideal time. So 6 weeks would be a fair amount of time to start a oral trial. Dr. Pavan Vadhavan from Panipat has this question. What is the maximum dose of glargine and degludec that can be safely used? You can go up to as much as you want. Some pens allow you to go up to 80 units, others allow you to go up to 60. In general, if you're crossing something like 40 units per day, it would be a good idea to give 20 units BD of glargine. That will help much more than 40 units at night. Degludec is ultra long acting, so you usually do not need to give twice a day. Once daily, you can go up till 40, 50, 60, 80 units. Another question from Dr. Pavan is about carbohydrate insulin ratio. So carbohydrate counting is something that we do use in type 1 diabetes in children. But in type 2 diabetes, it doesn't work. The reason is that insulin deficiency is there in type 2 diabetes, but it's predominantly insulin resistance. So therefore, each patient will have his or her own behavior with response to carbohydrates. Having said that, we should encourage our patients to take less carbohydrates. We try to encourage them to increase the proteins in their diet and also increase complex carbohydrates. Dr. Sandeep Kirat has a question. A typical picture of metabolic syndrome, but is this insulin resistance or not? How do I define whether a patient has insulin deficiency or insulin resistance, apart from the clinical presentation? So there are many biochemical ways of doing this. The simplest one would be a glucose triglyceride index. The formula is quite complicated, but if you have a patient with high triglycerides, like you have shown 435 in your patient, this is a surrogate marker of high free fatty acids, which in turn is a surrogate marker of insulin resistance. So a high triglycerides is the simplest biochemical parameter that you will have for insulin resistance. C-peptide, some people do it in clinical trials, in research settings. In normal OPD, we do not need to do C-peptide at all. Some people do it before bariatric surgery to predict whether the patient will go into remission or not. The reason why we do not do C-peptide is there is confusion about whether to do C-peptide fasting or postprandial or post-load. If you have a patient with, as it is, very high circulating glucose levels, patient has uncontrolled diabetes, then the question is, does it make sense to give a load at all or to do a postprandial C-peptide? C-peptide should be high all the time. So therefore, usually we do not do C-peptide. Like I said, glucose triglyceride index would be the best way. Another question asked is about HOMA IR or HOMA beta. Again, these are for research settings. So we actually do not need these to decide treatment. In a patient with a fasting of 235 and PP of 275, this means that there is predominant fasting hyperglycemia. So we would want to give more of basal insulin, more of metformin, relatively less of prandial insulin, relatively less of sulfonylureas. We also see that the patient has a low HDL, just 29. The best treatment for this is physical activity. So we would encourage our patient to follow physical activity. Another question is again from Dr. Sandeep. Can I use premix with breakfast and basal at dinner? I do use it sometimes. Example would be a Jain community. They have a heavy breakfast, and then there are many Jain patients, elderly patients, who will not eat food after dusk. So sometimes I use a hetero mix regimen. That would be 50-50 premix in the morning and 25-75 or 30-70 at dinner. At other times, I use the regimen that you say, premixed with in the morning and basal at dinner. And this is used in patients who are at very high risk of hypoglycemia. In my practice, the commonest indication for this regimen would be an observant Jain patient, elderly patient. Okay, this very good question. Dr. Anupam says, can PP be lower than fasting? The answer is yes. When I was an MD student, we had only one differential for this. And the differential was the laboratory people don't know how to check glucose. But now we understand that at least I understand now, I did not understand 25, 30 years ago, that fasting glycemia is mediated by the liver. Postprandial glycemia is mediated by lifestyle and by glucose uptake into the adipose tissue and skeletal muscle. So if your patient has a fasting of 112 and a PP of 86, number one, this is possible. Number two, you counsel your patient, thank you for taking care of yourself. Thank you for optimizing your lifestyle. That is why your post-lunch glucose is optimal. The fasting is slightly high. At 112, we do not need to add a tablet or increase any tablet. But maybe a 10 or 15 minutes walk after dinner might help. Maybe, like Dr. Pavan said, carbohydrate counting. You can reduce the carbohydrates at dinner time, reduce the chapati or rice, increase the protein content, the dal or the paneer or the curd, and see what happens. If we extend this further, Dr. Anupam, there is a disease called reactive hypoglycemia. What happens is you have a normal glucose fasting, maybe 90, then you take a meal, and 2 or 3 hours after the meal, usually 3 to 3.5 hours after the meal, the body reacts and goes into hypoglycemia, 50, 60, 70, much below the fasting, and this is symptomatic also. The reason is that as glucose levels increase after taking the meal, insulin is supposed to increase concordantly. But in such patients, there is hypersecretion of insulin, and there is discordance between the glucose rise and the insulin secretion. So at about 3.5 hours, the insulin levels are exceptionally high, while the glucose excretion is coming down. The glucose absorption has finished. And this leads to reactive hypoglycemia. This is something that many of us experience in the OPD. In the OPD, what you will see is that at around 12, 12:30, 1 o'clock, you begin to get irritated, hypoglycemic. This is also known as the hypoglycemia aggression hypothesis. And this was found in South America, in a particular Indian tribe, which was more aggressive than the tribes surrounding it. And an American anthropologist actually studied this tribe and found out that they have lower glucose levels as compared to people from other tribes. So if you're experiencing hypoglycemia aggression in your OPD pre-lunch, this is actually a mild form of reactive hypoglycemia. Do note, however, that reactive hypoglycemia is considered a pre-diabetic state. And because it's a pre-diabetic state, you have to take care of yourself. There's another question from Dr. Rodriguez. HbA1c in renal disease is not all that reliable. The reason is anemia and also low turnover of RBCs. So actually, in renal disease, HbA1c will underreport the glucose level. Dr. Kashinath Dixit says, how common is diabetes in hypothyroidism? It is quite common, sir. Uh, there is no association between type 2 diabetes and hypothyroid. However, there is an association between type 1 diabetes and hypothyroid. Both are autoimmune. Type 2 diabetes and hypothyroidism both are linked by insulin resistance. Both have insulin resistance. When do we stop OADs in patients on insulin? It will vary from patient to patient. Depends upon why we started in the first place. If you have a patient with recent onset diabetes, short duration of uncontrolled diabetes, a very clear-cut reason for the poor control, and you have been able to correct that reason, whether it was medical or surgical or psychosocial, then we can think of stopping OADs. Also remember that the patient should have good hepatic function and renal function before you think of stopping OADs, stopping insulin and starting OADs. If, however, the patient has long-standing diabetes, long-standing poor control of diabetes, there is no single reason for poor control that you can identify and therefore that you can correct, and patient may be having renal impairment or hepatic impairment, then it would be a good idea to continue insulin. Dr. Surinder Gupta opines that many times patients take high potency sulfonylureas even though they don't need it, and they're doing well even with non-secretagogues, right? Why that patient was suffering from hyperglycemia and nocturnal polyuria? See, if the patient has nocturnal polyuria, there has to be a reason. It can be diabetes, it can be UTI, it can be benign prostatic hypertrophy, it can be other causes. So we need to find the reason for nocturnal polyuria. First, we correct the hyperglycemia. If we are able to correct with non-secretagogues, fine. But if not, do not hesitate in using sulfonylureas. However, do use the modern ones only, glimepiride and glyclazide MR, and do not use high potency sulfonylureas. Stop at 50% of maximum dose, which would be something like the maximum we should use in our practice would be 4 milligram of glimepiride and maybe 120 milligram of glyclazide MR. Dr. Bimla Kapoor describes a patient, a 70-year-old patient with on insulin, Novorapid 10 units, 8 units, and 8 units, and Rizodex 16 at 10. Okay, so there is an error here. And also MF2BD, metformin 2BD, and Glixambi 1, and HbA1c is more than 10. So first of all, we need to find a reason for the high HbA1c. There will most probably in this patient be some sort of an infection, an inflammation, an invasion, or an irritation, a psychosocial irritation, or maybe an iatrogenic reason. Patient may be taking some over-the-counter preparation or some Ayurvedic preparation which we are not aware of. The second is to look at injection technique and injection choice. Now, Novorapid is rapid acting, so we can give 3 shots a day. But Degludec is the long acting one, so we should give Degludec at night. The trade name is Tresiba. If we do not want to use that, we can also use Toujeo or Levemir or Lantus or Bezaglar. Rhizodec, what you have mentioned, is a co-formulation. It is pre-mixed. So this contains 30% of Novorapid and 70% of Degludec, which means that when we are giving 16 units at 10 p.m. to the patient, number one, there's a risk of hypoglycemia 2 to 3 hours after that because there is 5 units of Novorapid in it. Secondly, it's just a total of 10 units of basal acting which is being given. And this 10 units of basal acting will not suffice to control the fasting glucose. We should also remember that in most patients, not in all, but in most patients, the rapid acting component will be about 55 to 60%, and the basal component will be 40 to 45%. If we look at this patient, we are giving 10 plus 8 plus 8, which is 26 units of rapid acting, plus another 5 from the Rhizodec, that's 31 units of rapid acting, and only 10 and a half units of basal. So this is a 3:1 distribution, while actually we want 1:1 distribution. So we can keep the Novorapid same perhaps, but increase the dose of Degludec at night. We should continue metformin and continue Glixambi. At 70 years old, make sure that the patient does not have a urinary tract infection or a genital tract infection. If this is there, then we need to stop the empagliflozin component of Glixambi. Also look for injection technique errors. Is the patient taking injection properly? Look at the injection site. Is there lipohypertrophy or not? Maybe patient is injecting into the lipohypertrophic site, and that is retarding absorption from there. Uh, like I said, I apologize once again. We've not been able to take the non-diabetes related questions, and हिंदी के लिए आपके साथ हमेशा हाजिर रहेंगे 7 बजे शाम सोमवार और वीरवार को. Dr. Amit Patel has a question about diabetic neuropathy with positive symptoms, that is tingling, as well as negative symptoms, loss of sensation in the legs. So we need to, of course, first of all, achieve good glucose control, strict no to tobacco, use a good neurotropic vitamin, anything of your choice, ensure that vitamin B12 and vitamin D are optimized. And for the tingling, good drug of choice would be either pregabalin or gabapentin. If your patient is obese, takes alcohol or other drugs, you can start pregabalin 75 milligram. If, however, patient is thin, non-obese, and is not used to taking alcohol or other drugs, then gabapentin 100 milligram would be a safer drug to begin with. If patient complains of lack of sleep, inability to sleep because of this tingling, then if pregabalin 75 doesn't work, you can always go up to 150, or you can add amitriptyline 10 milligram. There are many fixed dose combinations available. For those with micro or macroalbuminuria, 4 things. Optimize blood pressure. Use an ACE inhibitor. If ACE inhibitor is not tolerated or not available, then use ARB. Number 2, optimize glucose. Remember to use, to the maximum possible, an SGLT2 inhibitor or linagliptin. These are known to reduce albuminuria. Number 3, avoid acute precipitants like urinary tract infection or maybe obstruction. Number 4, stop tobacco. So 4 things for albuminuria. Optimize blood pressure using ACE inhibitor first or ARB second. Number 2, optimize glucose. Do use an SGLT2 inhibitor and linagliptin. Use insulin if indicated. Number 3, avoid acute precipitants, urinary tract infection, urinary tract obstruction, and use of renotoxic drugs. And number 4, strict no to tobacco. Dr. Sharda asks if metformin can be used for weight reduction. Sir, some studies have used, but in general, it is not proven to be effective for weight reduction alone. A better drug would be orlistat or injection liraglutide. We've taken all the questions. For those who have diabetes and who have joined with us, feel free to take fruits if you are well controlled. Small amounts of fruits at regular intervals. You can take a fruit separate from a meal as a snack, and this will prevent overburdening of your body with calories at any given point of time. We have all these questions answered for today, and I'm sorry that we have skipped the questions for this week. Ritu, if you have the slides and if you can show us. Otherwise, if you can just wait for a minute, I'll share the questions. It is heartening to see so many people logging in on Sunday night at such a late time. And I thank everybody for sparing their time for us. But diabetes is a really important issue. We cannot we cannot let this be. We just have to fight diabetes, and if we do that, we will be able to overcome this illness. We may not be able to overcome diabetes, but we'll certainly be able to overcome the complications of diabetes. So we can live with diabetes, but we should be able to prevent our countrymen and women from getting the complications of these drugs. Okay, so we have the questions. This disease is not related to the circulatory system. A, diabetes. B, hypertension. C, diphtheria. and D, coronary thrombosis. So, which of these is not related to the circulatory system? Diabetes, hypertension, diphtheria, or coronary thrombosis? Our second question, the Enerzal zero question of the week. A patient presents with decreased deep tendon reflexes, muscle weakness and fatigue, and altered LOC, constipation, and abdominal pain. What electrolyte imbalance is suspected? Is it A, hypernatremia, B, sorry, hyponatremia, B, hypocalcemia, C, hypercalcemia, and D, hypomagnesemia, just hypomagnesemia. So once again, patient presents with decreased deep tendon reflexes, muscle weakness and fatigue, uh, constipation and abdominal pain. What is the electrolyte imbalance that you suspect? Is it low sodium, low calcium, high calcium, or low magnesium? We'll meet again next week, next Sunday, same time, and we'll have the answers to these questions. Thank you, and thanks a lot for your patience this week.
Thank you, sir. Finally, you could take all the questions, and I'm very happy that all the viewers who were eager to see you and taking the live questions are actually finally relieved. And you have taken, I think, 15, 20, more than 20 minutes of live questions answer sessions, and that's the I think hallmark of our 52 weeks Diabetes Essential with Dr. Sanjay Kalra, because at the end of the day, all the practical questions are being taken by you, and I think that's the message we are giving to all the people who are not attending maybe regularly, or those who are maybe not aware of it. I request all my current viewers to talk to your colleagues that at the end of every week on Sunday 9 p.m. Dr. Sanjay Kalra is available to take care of all the clinical questions which they may be figuring out or may not be able to figuring out, especially of I've seen looking into the questions of insulin and insulin related and maybe triple drugs and insulin combination related questions have been handsomely taken by Dr. Sanjay Kalra. I'm very thankful to you, sir, and looking forward to see you next week. Thank you very much. Jai Hind.
Jai Hind.